Good evening, Professor and colleagues. We are proudly presenting in this session very eminent international figures in nephrology and in dialysis. This session will be in advances in CKD and hemodialysis technology. I hope that we all will enjoy the talks from our professor in this talk. Thank you very much. We should start.
Okay. Hello, Mr. Chairman and all my colleagues, dear professors and friends all over the world. It's my pleasure to share this session with my professors, Professor Magdi Sharqawi, and thank him very much for his inviting us to just share with him this very magnificent event. Dr. Hisham Sayed, the Professor of Nephrology in Shams University, Dr. Walid in Shams University, and Dr. Yasser from Cairo University, and Professor Tariq Tantawi, Consultant of Nephrology. It's my pleasure to be with you, and it's a real pleasure to introduce Professor Nicola Warren. She's a head of nephrology and consultant of nephrology at Groote Schuur Hospital, Cape Town University, and she is head of peritoneal dialysis and HIV renal clinic in the division. And Professor Nicole will just give us a very important lecture about continuous ambulatory peritoneal dialysis updates. Please, Professor Nicole.
Welcome everyone, I'm Nikki Wern. I'm one of the consultant nephrologists at Fruitus Care Hospital in Cape Town. I run the PD unit. We offer a PD first program and I look after about 50 PD patients. I feel very honoured today to be here and thankful to the organising committee to allowing me to give you an update on continuous peritoneal dialysis. I just wanted to start by alerting everyone to this document that was recently published in PDI regarding high quality goal-directed PD. A theme that strongly resonates throughout this paper is that of shared decision making. The relationship between the PD team should be to establish realistic care goals that maintain quality of life by enabling patients to meet their life goals, minimizing symptoms and treatment burden while ensuring high quality care. So the outline of my talk today will be to describe the survival benefit of PD and review the current literature, the importance of residual kidney function, how we can protect the peritoneal membrane, and the holy grail of PD fluids, which we're not quite there yet. And then I'm going to finally finish by describing a little bit about incremental PD and how that can fit into the care plan for the patient. So why do we like PD first and not HD? Well, it offers patient autonomy, improved flexibility and quality of life. As I've described, there are mortality benefits, particularly in the first couple of years. There are no VAS caths, hopefully, which are associated with increased mortality. Evidence supports PD to protect residual kidney function. And then in some areas, like in South Africa, there are restricted numbers of hemodialysis slots. And in some cases, for example, in sub-Saharan Africa, there's no hemodialysis at all. So people rely very heavily on PD. So what are the survival benefits of PD? I will give you a bit of an update here. As early as 1997, Fenton et al. Showed that PD has a survival advantage, particularly in the early years of treatment, that is up to 2 to 3 years, that is sustained up to 2 to 3 years, and then the playing fields tend to level out. The landmark Canusa study focused more on the dose of PD, where the initial results demonstrated that urea and creatinine were strong predictors of mortality in PD patients, and for each 0.1 unit of KT over V per week was associated with a 5% decrease in the relative risk of death. And residual kidney function was not, however, residual kidney function was not examined as a risk factor in this study as one of the clinical outcomes. So the reanalysis of this landmark study by Joanne Bargmann in 2001 revealed a very different story. And when the CANUSA was reanalyzed, the aim of this study was to assess the separate contributions of peritoneal and renal clearances and determine the contributions of residual kidney function on outcomes. And what it showed was that for every 5 liters per week or 0.5 mils per minute in GFR, there was a 12% reduction in relative risk of death. And this was not associated with peritoneal creatinine clearance. So what does this really mean? Well, when we tease it all out, what it means is for every 250 ml increment in a patient's urine volume, there was a 36% decrease in the relative risk of death. And neither net peritoneal ultrafiltration nor total fluid removal was associated with patient survival. And the contribution of residual kidney function was much more important than peritoneal clearance. And therefore, residual kidney function is an extremely important predictor of survival. So a more recent study performed in 2014, it was a population average adjusted patient survival for propensity score matched HD and PD by method of analysis. And you can see the shared errors reflect where the point-wide difference in the two survival curves differ. And here you can see the top graph clearly shows a survival benefit of PD. This is true even for diabetics, although diabetics as a whole have worse outcomes compared with non-diabetics in both the HD and the PD group. A very recent publication that was published this year discusses why PD prior to HD remains very important in 2020, and this paper reviews all the current evidence. It reports that there still is much evidence supporting better residual kidney function with PD, that the use of central venous catheters remains associated with increased mortality compared to AV fistulas due to increased infectious complications. However, the downside is that the peritoneal membrane is exposed to dialysis solutions, which eventually leads to changes in the peritoneal membrane with more fibrosis, decreased ultrafiltration, poorer volume control, and possibly loss of nutrients due to rapid transport, thus increasing the mortality. So the same paper performs a meta-analysis of cohort studies comparing risk of death in those treated with HD versus PD. And the graph to the right summarizes the relative risk of death at 6 months, 1 year, and 2 years. And here you can see clearly that there's an improvement, that the relative risk of death in PD is maintained through the 2-year period. The paper also, it also describes how shared decision-making is very important and a fundamental patient right, which requires a consensual decision based on shared understanding and values. That pre-dialysis education is very important, and if it occurs, it is actually responsible for people choosing PD 50% of the time. And a cornerstone of this process should be an explicit discussion on the early survival benefit of PD relative to HD. I'm going to move now on to the importance of preserving residual renal function. This patient was also published this year. And what it outlines is the evidence regarding residual renal function, so residual kidney function. So I'm just going to go through the current evidence. Residual kidney function is an important component of well-being and survival and should be monitored periodically, and the recommendation is to do it quarterly. It is best assessed by averaging the urinary clearances of creatinine and urea, and it may be monitored as the renal KT over V urea. However, urinary volume should also be measured. When it comes to residual kidney function, there is no clear evidence supporting one PD modality over another. Thus, the choice for modality should be based on preference. PD solutions with neutral pH and low GDP seem to have a favorable effect on residual kidney function. I'm going to go in this in a little bit more detail later. And ACE and ARB should be used whenever possible to preserve residual kidney function and decrease cardiac mortality. Loop diuretics and icodextrin help with maintaining fluid balance. However, caution should be taken to avoid volume depletion that could adversely affect residual kidney function. The short-term use of aminoglycosides does not have a detrimental impact on residual kidney function, but long-term use, more than 3 weeks, should be avoided due to the risk of ototoxicity, and other potential nephrotoxic agents such as IV contrast should be used with caution. What about the role of incremental dialysis for protecting residual kidney function? Incremental dialysis is the practice of initiating PD exchanges less than 4 times a day, so less than the standard practice for PD, and increasing the dialysis dose in a stepwise manner as the residual kidney function decreases. So this very recent report describes how incremental PD may be beneficial for preserving residual kidney function compared to full dose PD. It was a single center trial. It was retrospective. It was performed in Seoul. There were 347 PD patients, 176 with incremental PD and 171 with conventional full dose PD. The incremental PD group had a lower risk of developing anuria, which was significant. However, patient survival, technique survival, and peritonitis-free survival were all similar between the groups. There was no significance here. And this paper has a statement stating that incremental PD was beneficial for preserving residual kidney function and showed similar patient survival when compared to conventional full-dose PD. So how can we protect the peritoneal membrane? Very important. The peritoneal membrane, we know, changes over time with PD. Here you can see a diagram, quite an old study, but you can see the mesothelial layer and the peritoneal membrane in a normal control, and then what it looks like after 9 years on peritoneal dialysis. And I'm just going to go through the contributory negative effects on the peritoneal membrane, which include the PD fluid itself, the systemic PD effects from the glucose degradation products and advanced glycosylation end product accumulation, inflammation, insufficient toxin removal, and fluid and salt overload. And then there are local PD effects that also affect the membrane. And all of these contribute negatively to the peritoneal membrane. The mechanism of inflammation is multifactorial and involves the activation of TGF-beta, growth factors, and hypoxia. And these inflammatory pathways promote fibrosis, angiogenesis, and lymphangiogenicis. Now, the holy grail to the ultimate PD fluid hasn't actually been reached yet. So we start with our conventional glucose-based PD fluids, which contain glucose degradation products. We now have the second generation glucose PD fluids with the multi-chamber bags reducing GDP generation during sterilization. We also have alternative osmotic compounds, including amino acids and icodextrin. And we're now moving into the era of protective agents that may counteract local and systemic PD fluid toxicity. One of these such agents is alanine glutamine supplemented PD fluids. But the fourth generation PD fluid, which is the ultimate PD fluid, reflects the vision of a PD fluid that actually will not harm the membrane. So the biocompatible fluids aim to reduce glucose degradation products and advanced glycation end products. They aim to preserve the membrane function, protect against peritonitis, thereby preserving membrane function, and preserve residual kidney function. As you can see in the diagram, the glucose and bicarb buffer are in 2 distinct compartments, and in the top compartment with the glucose is kept at a low pH, and the low pH is responsible for the lower GDP levels during the sterilization process of the fluids. So I'm just going to go through some of the landmark trials with the biocompatible fluids. The BALANCE trial, now quite an old trial, performed in 2020, demonstrated that time to anuria was significantly slower with the biocompatible fluids using Physionil, and the rate of renal decline of residual renal function improved, but was not statistically significant. It also demonstrated that the time to first peritonitis was longer with the biocompatible fluids. This is the second Cochrane review of biocompatible dialysis fluids, and it was released in 2018. More studies, including 6 new studies, and it compares the neutral pH, low GDP PD solutions with conventional PD solutions, but there were also a subgroup of studies comparing icodextrin with conventional PD solutions. And the summary of the findings of this Cochrane review show that the evidence now is strengthening that neutral pH, low GDP PD solutions improve residual kidney function and urine volume preservation with higher certainty. And the effects may be related to increased peritoneal solute transport and reduced peritoneal ultrafiltration, but the evidence for these outcomes is of low certainty. Icodextrin increases peritoneal ultrafiltration and mitigated uncontrolled fluid overload with moderate certainty, and the effects of either neutral pH low GDP solutions or icodextrin on peritonitis, technique survival, and patient survival remain uncertain and require further high-quality, adequately powered randomized controlled trials. So I'm just going to go through some of the one or two of the important figures or graphs in this Cochrane review, and here you can see the low GDP solutions versus the standard glucose dialysate on residual kidney function. And on review, one can see that overall it favors the low GDP solutions at 24 months. The evidence also continues to support a reduction in inflow pain with low GDP solutions, which was also seen in the BALANCE trial. Icodextrin, a glucose polymer, protects against fluid overload. This is clearly seen to the left of the line, where you can see that there's a favoring of icodextrin to prevent fluid overload. And icodextrin does not have a major impact on residual kidney function. The initial thought was due to excessive ultrafiltration, it may actually have an impact on this, but this systematic review does not demonstrate that. So I just want to move on a little bit more. We've talked about our biocompatible fluids and our icodextrin, and I just want to move on to the protective agents that counteract local and systemic PD fluid toxicity and discuss in a little bit more detail the alanine glutamine supplemented PD fluids. So this article that was published in 2018 asked the question, does alanine glutamine supplementation offer potential to improve peritoneal dialysate biocompatibility? The mechanism of action of alanine glutamine, it has a beneficial effect it has a potential beneficial effect by replacing deficient glutamine in order to restore dysfunctional mesothelial cellular stress responses. The cellular mechanisms are complex, but they include enhancement of heat shock protein 72, thereby strengthening resistance of mesothelial cells against toxicity from PD fluids. And there was a recent randomized controlled trial whose aim was to add alanine glutamine to biocompatible PD fluids with the objective of improving markers of mesothelial cell health. And this trial, the results of this trial, there were 8 Austrian centers with 50 patients randomized. And what came out of the trial was that alanine glutamine supplemented PD fluid improved biomarkers of peritoneal membrane integrity, immune competence, and systemic inflammation compared to unsupplemented PD fluid with neutral pH and low glucose degradation. However, they recommend that a phase 3 trial is needed to determine the impact on hard clinical outcomes. So I want to finally talk about individualizing the PD prescription and a little bit about incremental PD. An incremental PD is something that I like to practice myself. And really what it is that less than standard full dose PD is initially prescribed in recognition of the value of preserving residual kidney function. So one may start with 3 PD bags rather than 4, for example. Peritoneal clearance is initially low. However, the combination of peritoneal plus renal clearance aims to achieve or exceed goal clearances. There is clear intention to increase the PD dose as renal clearance declines and or symptoms appear. And therefore, incremental PD lessens the patient workload by reducing the number of bags. It reduces the cost and it reduces glucose exposure. Currently, the hard evidence that incremental PD improves clinical outcomes compared to the use of full dose PD is lacking. However, recent evidence is supporting and suggests that outcomes are at least as good as standard PD prescriptions. So in conclusion, evidence continues to support a survival benefit of PD over HD, particularly in the early years. PD remains an important modality for maintenance of residual kidney function. We still haven't achieved the holy grail of PD fluid. However, increasing evidence is supporting biocompatible fluids for enhancing residual kidney function. The evidence does support icodextrin for the prevention of fluid overload. Alanine glutamine added to PD fluid shows promising results. And finally, incremental PD should be part of individualizing patient care in a peritoneal dialysis program. And I just want to thank you very much for your attention.
Thank you, Professor Nicole, for your valuable updates in CAPD.
Okay, we'll move to the next speaker.
Next one.
Let me move to the next speaker, Professor Tarek El-Paz, as the President of Egyptian Society of Nephrology and the current President of Arab Society of Nephrology. He will speak to us about the microbiome and CKD. Please, Dr. Tarek.
Everybody, I don't know if I'm in the morning or in the evening. I'm very happy to be joining this meeting, and of course being president of the Arab Society of Nephrology and having this meeting endorsed by our society is a great opportunity for all the Arab countries that I hope they are online with us and seeing this wonderful meeting. My congratulations to Professor Magdi Sharqawi and Hisham Al-Sayed and all of my friends from Mohin Shams, Dr. Huwaida Shinawi, and everybody else that really shared in organizing this meeting. I wish you all the luck and all the success. Firstly, I want to address logic. And when I'm talking about logic, I don't mean the logic that was founded by Aristotle so many centuries ago, but rather the modern logic that was founded by philosophers in the late 19th and early 20th century. What is logic? There are various definitions for logic. You can say that it is the way facts or events follow or relate to each other. When we come to medicine, we find the definition is a little bit different because it is the sum of the total of education and experiences that one has that are integrated in the physician's mind in order to be able to take a medical decision making this process valid. Well, mathematics and computer science logic are quite different from real life logic and definitely from medical logic, because the variables here are so plenty. And I'm going to give you an example about this. If we are going to follow logic, it doesn't have to really apply and result in a positive logical equation. Statins are very effective drugs in lowering the cholesterol and have been shown as preventive for heart attacks and strokes, and everybody knows this, and it's a guideline, and they are wonderful medications. Moving on to nephrology and statins, we found that there are contradictory findings that people with CKD who have increased risk of cardiovascular disease are allowed or would benefit from statins up to stage 4, but once the patient progresses, all trials told us it may be even harmful to give patients statins. So if you are going to extend your use of statins to patients on hemodialysis, you're not supposed to do that except in a very small margin of patients that are already on statins and are really high risk patients. Otherwise, you would be afraid of possible adverse events and other complicating risks. The vasculopathy occurring in chronic kidney disease, naturally, as we all know, is a multifactorial one, and only the dyslipidemia and particularly hypertriglyceridemia that is occurring in chronic kidney disease patient is just a small fraction of these noxious factors that affect the vessels. So here we find that the logic is not giving us a positive result, but this doesn't mean logic is not right. We shouldn't use it, yes, but we have to understand that sometimes the variables outweigh the results of following simple logic. Why I'm talking about this? Because I'm going to talk about the microbiome and show you some already published data about microbiome interventions in chronic kidney disease, and is it logical to extend these results to hemodialysis patients as well, yes or no? So let me start by showing you this slide describing this dysbiosis that has been implicated in various disease areas, whether obesity, type 2 diabetes mellitus, inflammatory bowel disease, cardiovascular disease, and today I will be addressing the progression of chronic kidney disease related to this dysbiosis. If I can expand a little bit this slide, maybe I can show you that the toxins released from the gut once the barrier, the physiological barrier is breached are here: trimethylamine N oxide, indoxyl sulfate, p-cresol sulfate. These are very serious toxins to the cardiovascular system. Once they reach the circulation, they initiate a serious inflammatory reaction that would result in progression of chronic kidney disease, affection of cardiovascular system, potentiation of what's already happening in atherogenesis and so forth. So this dysbiosis is actually related to various disease areas. I want to say there are so many disease areas related to this dysbiosis, even depression, insulin resistance, and the resultant diabetes, as I just mentioned. The immune system also is affected by this dysbiosis. We're looking at this diagram just to underline the fact that the gut dysbiosis is related through inflammation to the occurrence of insulin resistance. I just mentioned that, progression of chronic kidney disease, and also something very important is immune dysregulation. this immune dysregulation will definitely reflect on a higher incidence of infection that would accelerate the occurrence of the chronic inflammation that is leading to the pathology in these areas. We have to concentrate a little bit on these two important toxins that are leading to leaky blood vessels, and they are released from the gut due to the accumulation of these uremic toxins within the gut once the pathobionts are active and the commensals colonies have. This sky blue background represents the physiology of the gut. Everything is fine. There is a symbiotic gut microbiota. The commensal bacteria are abundant. The barrier is integral here. There is no inflammation, and this is due to the presence of this receptor called the pattern recognition receptor, which aids this ancient antimicrobial polypeptide or peptide, which helps in repelling whatever pathobiont wanting to breach through the barrier. Also, the immune system has been able to identify such pathobionts, and the activation of B cells and releasing specific immunoglobulin A helps in keeping the state steady, and everything is quiet, as you can see, and there is a tolerant immune response so far, and the balance between the commensals and pathobionts is physiological. In CKD, we find that there's increased concentrations of uremic toxins within the gut, which lead to a deprivation of the gut or a decrease in the colony count of commensals that we need for various physiological necessities of the body, and a resultant overgrowth of pathobionts that we really don't need. And these biobionts have the capacity to make a passage or breach the integrity of the previously shown barrier and to reach the circulation, whether as bacteria by themselves or by letting their endotoxins or the endotoxins present in the gut to pass into the circulation. In this slide, I'm just referring to the lipopolysaccharides, which is the coating of the bacteria. Once reaching the circulation, it can bind to a specific receptor on the macrophages and start a serious inflammatory cytokine release with a resultant inflammation. The dysregulated immune response also that I have mentioned earlier, and the chronic production of the pro-inflammatory cytokines together are sharing in this systemic inflammatory process. And this systemic inflammatory process, naturally, we all realize and comprehend a serious effect on the blood vessels, as well as the progression of chronic kidney disease and chronic and cardiovascular disease as well. Now, the scene is different. It is on fire, meaning that there is dysbiosis occurring in the chronic kidney disease gut. Intestinal urea and ammonia are in excess, as you can see here underlined. The pathobiont overgrowth is going on, and the barrier has been breached, and all of these toxins are passing into the circulation, leading to the inflammation and dysregulated immune response, affecting the immune system, generally speaking, which is sharing in all the damage that's happening, whether to the kidney or to the blood. The serious endotoxins that I'm talking about are the indoxyl sulfate and the peak resol sulfate, which is sometimes described as peak resyl sulfate. They are very serious toxins to the blood vessels, and they increase the vascular permeability together with whatever variables are present, such as hyperparathyroidism, calcium, deficiency of vitamin K. A lot of other factors in uremia are also affecting the blood vessels, but the elevated levels of indoxyl sulfate have been associated with vascular stiffness and aortic calcification, like other things in chronic kidney disease. So they are very serious toxins, not only to the blood vessels, but have been described to be related to progression of the disease itself, as well as cardiovascular. And this slide depicts the central role of indoxyl sulfate. It's not only related to this type of vasculopathy, but you can see depicted here its relation to vascular access thrombosis that our patients sometimes suffer from, peripheral arterial disease, even arrhythmias. Arrhythmias not just due to hypokalemia that may occur at the end of dialysis, but the levels of this toxin, if not removed efficiently, may be also related to arrhythmias, heart failure, and definitely atherogenesis or atherosclerosis, so to speak. What's happening in chronic kidney disease? You are depriving your patient of the usual fiber diet, feeding hyperkalemia, and mind you, this statement is not all that right nowadays, because it has been proven that depriving the patient of potassium, particularly early in the stages of chronic kidney disease, is doing rather damage than doing good. Patient needs potassium in order to prevent the progression of chronic kidney disease and other factors. So naturally, what is happening if you are depriving the patient of the fiber? There is a decrease in the production of the short chain fatty acids, and these are very important because the body needs them for the integrity of the enterocytes. Also, this results in alteration of the gut barrier and breaching, and what I have been saying earlier related to the chronic inflammatory response that is going to happen. If patients on with chronic kidney disease have an increased protein in their diets, this results in excessive protein in the gut and resultant fermentation. There's a lot of acids and toxins and increased proteolytic microbiota that are doing further damage, with resultant increase in the levels of indoxyl sulfate and piperosome and TNO. All of these, if there's breaching of the gut, they will reach the circulation and the trouble starts to happen. For many years now, or many decades, scientists and physicians in particular are aware of aging. Aging, when we address aging, I don't mean how the way we look, wrinkles and loss of hair and so forth, but rather what aging brings to us. Aging brings Alzheimer, easy falling, osteoporosis, fractures, cancers, metabolic diseases, and so forth. We are trying to fight aging, and one of the important aspects of aging is the inflammaging. Inflammaging is a state of chronic inflammation occurring with aging, and the blood vessels, as the other organs, also age. Let me show you this slide addressing the endothelial vascular aging known as EVA, and how that endothelial senescence is sharing in the occurrence of EVA together with the endothelial chronic inflammatory state related to these factors, whether telomere attrition that has been shown to be attenuated with the use of metformin, the low Phenytoin level. I think we know that it is there in chronic kidney disease. A lot of oxidative stress also is present, decreased amounts of clotho, all of these together, and today I'm adding the microbiome dysbiosis leading to the inflammaging and the endothelial chronic inflammatory process that will eventually lead to endothelial vascular aging. It's a very serious condition. This is just simply showing you what's happening. It's much more sophisticated than that, but today I just want to limit the talk to the microbiome dysbiosis to show you that it also affects the vascular aging in chronic kidney disease. The excessive uremic toxins, according to this publication, has been documented to be a result of the gut microbiota. So this axis is a very serious one, and we have to do anything in order to alter this dysbiosis, helping to lessen the production of the indoxyl sulfate and piperosol and whatever else. And this has been documented in various publications. Now, intervening or intervention to this dysbiosis by probiotics has been shown in this publication and many other publications that using probiotics had a very beneficial effect and amelioration of the systemic diseases related to decreasing dyslipidemia, improving the glycemic profile, even the blood pressure, and other serious parameters of chronic kidney disease. So according to this publication and many, many others, I can't show everything or even part of them, I'm just picking a few today, gut microbiota intervention with probiotics have been shown to be a potential therapeutic target to lessen the cardiometabolic disorder. Now, systematic reviews, we all like systematic reviews, and the authors of this systematic review reviewed around 831 articles. Eventually, they chose only 20 studies examining the gastrointestinal microbiota in patients with chronic kidney disease, and they arrived at the conclusion that it is an effective way in improving various parameters related to the accumulation of the uremic toxins using the intervention or using the probiotics to treat patients with chronic kidney disease. And this was a very positive result. And this recent publication this year showed what I had earlier pointed towards is the state of the immune system and how that the immune system also is altered as a result of the leaky gut. Once the barrier has been breached and the toxins are reaching the systemic circulation, this affects the immune system and has been documented in this publication, as you can see. And they also found that there is a decreased number of the bacteria that are important for generating the needed short-chain fatty acids, which are important as a nutrient source for our enterocytes and are also helping to keep the immune system in an integral physiological way. So all of these clinical studies, according to this systematic review, point that using probiotics in the diet of chronic kidney disease patients could be helpful in slowing the progression of immune-related kidney diseases, and this is a new point. This is the way you're going to intervene, whether you're going to modulate the gut microbiota by giving the beneficial bacteria by probiotics, or blocking the lipopolysaccharide, or targeting absorption of these uremic toxins, let's say by activated charcoal. There are various ways. They are not the focus of my talk today. Moving on to hemodialysis, and let's see if intervention related to the dysbiosis in hemodialysis, is it doing anything good, or is it like the statins, not doing anything but even doing harm? Let's see what I have to show you today. And this exciting, very sophisticated experiment was published this year. It is sophisticated because the parameters that were used to analyze the results were quite significant. The trial consisted of 50 hemodialysis patients divided into two groups. The first group received probiotics, and the second group received simply placebo. Serum and fecal metabolome was studied to see the amounts and colony counts for commensals or pathobionts, serum albumin as an inflammatory marker, various endotoxins related to chronic kidney disease, even endothelial activation markers were assessed, as you can see, and they concluded that the probiotics might really modulate the intestinal dysbiosis and decrease the concentration of certain uremic retention substances in the circulation and improving the condition. This was much more apparent or more significant in patients who were non-diabetics. It seems diabetes is an added factor. Yet the results were good, and the primary endpoints was the fecal microbiota profile showing how the commensal counts of colonies increased, and the secondary endpoints was related to assessing the levels of the various inflammatory markers such as high sensitivity CRP, interleukin-6 and TNF-alpha, all of which showed significant improvement versus the placebo group, as well as also the epithelial activation markers, which are denoting that there is an inflammation or not. The effect of probiotics on inflammation and endemic toxins again was addressed in this publication, and again the conclusion showed that there is benefits of probiotic on inflammation and endemic toxins, and this is a very interesting publication where the authors try to test the different modalities of blood purification, whether hemodialysis versus hemodiafiltration or hemoperfusion, arriving to the fact that the standard microflora might be influenced by uremia, yes, as documented before, and may be affected positively by blood purification treatment, showing better results towards those patients who were on hemodiafiltration. In conclusion, ladies and gentlemen, increasing evidence shows a bidirectional relationship existing between host and gut microbiome in patients with various kidney disease. Intestinal inflammation and epithelial barrier breakdown does accelerate the systemic translocation not only of the bacteria but the bacterial-derived uremic toxins such as the trimethylamine oxide, picrazole, and the oxal sulfate, all of which have been implicated in the process of progression of chronic kidney disease and cardiovascular morbidity. And the data I have shown today is accumulating, and there is definite evidence for a role of probiotics in the treatment of chronic kidney disease patients as well as patients on hemodialysis. So my last slide, I'm going to ask the question again: does microbiome intervention in hemodialysis do anything that is good? Well, the current data that I have showed to you reveals that there is logic in using the microbiome intervention and expanding or extending its use from the stages of chronic kidney disease till at the end when the patient reaches dialysis, and it could be a good adjuvant therapeutic modality to help our patients. I thank you all for your kind attention. Once more, I wish you a very successful event.
My pleasure to introduce Professor Muntasir Zaid, Professor of Internal Medicine and Nephrology, Alexandria University, and he is the head of transplantation program in Mouassa Hospital. He will today address ECMO and kidney disease.
At first, I would like to thank organizing committee inviting me for this prestigious annual Congress. I will talk today about continuous renal replacement therapy during extracorporeal membrane oxygenation in patients treated in medical intensive care unit. ECMO, or extracorporeal membrane oxygenation, is a form of extracorporeal life support where an external artificial circuit carries venous blood from the patient to a gas exchange device, oxygenator, where blood becomes enriched with oxygen and has carbon dioxide removed. The blood is then returned to the patient via a central vein or an artery. History of ECMO starts from 1950 by development of membrane oxygenator in laboratory, and the first successful case was that of Esperanza, her photo here, where she is now 45 years. This photo was taken when she was 21 years. In 1972, first successful pediatric cardiac case and the first neonatal case Esperanza. In 2000, standard practice for adults in some centers, and in 2009, publication of the landmark study Caesar trial, which led to a significant growth in the use of ECMO for ARDS cases. The first successful extracorporeal life support patient treated by Donald Hill using Bramson, this oxygenator in this foreground. This is Esperanza when she was 29 years of age. Now she is 45. This is a diagrammatic illustration of basic ECMO circuit, which starts by vascular access and withdrawal of blood by a roller pump to pass through a membrane lung or oxygenator, and then to heater exchange, and then blood will return back to the patient. This is when they started ECMO therapy, and this is now the shape of the device. Circuit monitoring includes circuit blood flow, circuit gas flow, circuit pressure, circuit integrity, and these variables should be monitored continuously. The saturated blood is drained via a central venous cannula. CO2 is removed, the O2 added through an extracorporeal device, and the blood is then returned to systemic circulation via another vein, which we call veno-venous ECMO, or an artery, which is called veno-arterial ECMO. ECMO is a bridging therapy, bridging for patient to recover, bridge to decision, provide temporary support to patient, and allow clinicians to decide on the next step, and it is also a bridge to transplant, provide support to patient while awaiting suitable donor organ. The different configurations in ECMO, the most common are veno-venous ECMO, which used to support patients with severe respiratory failure refractory to conventional therapy. Blood is drawn from a central vein, passes through an ECMO machine, and then returned back via a central vein. Veno-arterial ECMO is used to support patients with severe cardiac failure with or without respiratory failure. Blood is drawn from a central vein, passes through an ECMO machine, and then returned back to patient via a central artery. This figure illustrates veno-venous ECMO cannulation by cannulating a femoral vein to withdraw blood to an ECMO machine, and then blood will return back through the femoral vein of the other side to inferior vena cava. In veno-arterial ECMO cannulation, blood is withdrawn from inferior vena cava to ECMO machine and then returned back to femoral artery to aorta. Sorry. We have 4 configurations of veno-venous ECMO depending on the cannulation site: femoro-femoral, high flow, femoro-jugular, and double lumen single cannula, what we call a balloon. Femoro-femoral ECMO starts by withdrawing blood from inferior vena cava through femoral approach, and then blood passes through ECMO machine and then back through femoral vein to right atrium. In high flow ECMO, blood is withdrawn from both superior and inferior vena cava and returned back to patient to right atrium. In femorojugular ECMO, blood is withdrawn from the femoral vein and returned to internal jugular vein to right atrium. And in double lumen 2-stage single cannula Avalon, blood is withdrawn from internal jugular vein by a single double lumen single puncture, and the blood is withdrawn from superior vena cava and inferior vena cava and returned to right atrium. An arteriovenous extracorporeal circuit that uses the patient's own arterial pressure or incorporate a pump to drive blood across an oxygenator can partially support the respiratory system by effectively removing carbon dioxide. This is called extracorporeal CO2 removal. We withdraw blood from an artery and return it back to a vein. So blood is withdrawn from femoral artery and returned back to inferior vena cava. The ranges of extracorporeal life support techniques are extracorporeal CO2 removal or full ECMO, veno-venous ECMO. The indications are reversible respiratory failure, ARDS, severe pneumonitis, severe acute asthma, chemical and inhalational hypersensitivity pneumonitis, near drowning, post-traumatic lung contusion, bronchiolitis obliterans, autoimmune lung diseases as in vasculitis and Goodpasture syndrome. Inclusion criteria include the presence of any two of the following criteria for over a period of 4 to 6 hours after maximum medical resuscitation. Partial pressure of O2 over FiO2 less than 65, oxygen index more than 40, Murray score more than 3, alveolar arterial gradient more than 600, hypercapnia with pH of less than 7.2, observed over more than 3 hours, lung compliance less than 0.5. The exclusion criteria for ECMO are disseminated malignancy, age more than 75 years, age more than 75 years, on ventilator more than 15 days, irreversible indeterminate neurological prognosis, immunosuppressed state, multiple organ failure, pre-existing coagulopathy, severe pulmonary hypertension, and severe aortic regurgitation. Complications are bleeding, thromboembolism, cannulation-related complications, heparin-induced thrombocytopenia, neurological complications, and the Harlequin syndrome, which is called north-south syndrome. Limb ischemia may occur, and in this case, a perfusion of the femoral artery by distal perfusion catheter is inserted in cases of arteriovenous ECMO. In this case of respiratory failure, flow competition in the aorta between the recovering native heart and the extracorporeal circuit can lead to what we call Harlequin or north-south syndrome, where deoxygenated blood supplies the upper part of the body and hyperoxygenated blood supplies to the lower part of the body. Treatment in this case include increasing ECMO flow if no cardiac stunning, higher ventilator setting to consider high-frequency oscillatory ventilation, switch to veno-venous ECMO if persistent lung failure. ECMO team comprises 2 intensivists, 1 medical officer to monitor cannula position by echo, 1 medical officer for clinical management, perfusionist, ECMO priming and maintenance, respiratory therapist for lung protective management and ventilator settings, nurses, and radiologic technician. ECMO procedure, we have to describe first the pump for ECMO device. It was before a roller pump, but now replaced by centrifugal pump. The perfusion pressure is controlled by revolutionary per minute from 0 to 4,000 revolution per minute, can deliver flows up to 8 liters per minute, and very reliable up to 21 days. ECMO circuit has a gas exchanger device called the oxygenator to add oxygen and remove CO2 blood. Previously, the hollow fiber was made from silicon membrane. Oxygenators were used and which are being replaced by hollow fiber polymethylpentene membrane oxygenator. These are extremely efficient at gas exchange and demonstrate minimal plasma leakage, low resistance to blood flow. Gas exchange depends on type of membrane and diffusion characteristics, thickness of blood pathway, surface area of the membrane, FiO2 in gas phase, and rate of blood flow. Heat exchanger in adults usually built in within the oxygenator. In pediatric cases, it is connected separately after oxygenator in circuit. The dual lumen cannula, what we call a balloon, one cannula inserted through right internal jugular vein, drainage from inferior vena cava and superior vena cava, lead to oxygenated blood return back to right atrium, and it is designed for application in adults. Tubings may be regular type or heparin-coated tube. In situations post-cardiothoracic surgery where ECMO support is anticipated, chest wall will be left open and covered by elastic patch, and burst string sutures will be left in place. ECMO mechanism starts by initiation, and once it has been decided to initiate ECMO, the patient is anticoagulated with IV heparin and the cannula inserted according to ECMO configuration, veno-venous or veno-arterial ECMO. Following cannulation, patient is connected to ECMO circuit, and the pump started with a flow of 20 ml per kg per minute and gradually increased to 5 to 10 minutes by 10 ml per kg per minute to reach the desired flow. Gas flow to blood flow is adjusted to be 0.5 to 1 and start with a FiO2 of 21% to be increased up to 100% FiO2. Once the desired flow achieved, ventilator settings are brought down to baseline. Once the initial respiratory and hemodynamic goals have been achieved, the blood flow is maintained at that rate. Continuous venous oximetry, blood pressure monitoring, mean arterial pressure, pre-pump pressure, pre and post oxygenator pressure, vital parameters, flow rate, blood flow rate at 60 to 150 ml per kg per minute, neurological status, vascular status to be monitored. Anticoagulation is sustained during ECMO with a continuous infusion of unfractionated heparin, titrated to with active clotting time of 180 to 210 seconds. The average duration for veno-venous ECMO from 14 to 21 days, and for veno-arterial ECMO from 5 to 14 days. For patients with respiratory failure, improvement in radiographic appearance and pulmonary compliance and arterial O2 saturation means we can start weaning. With cardiac failure, enhanced aortic pulsatility correlate with improved left ventricular output. One or more trials of taking off the patient of ECMO should be performed prior to discontinuing ECMO permanently. This is a landmark study of CESAR or CESAR study, which is a multi-center randomized controlled trial. It tested adults with randomized either to veno-venous ECMO at Glenfield Hospital, 90 patients, or continuing conventional care at referral hospitals, 90 patients. The aim of the randomized controlled trial of conventional ventilatory support versus extracorporeal membrane oxygenation for severe adult respiratory failure is to assess whether for patients with severe but potentially reversible respiratory failure, extracorporeal membrane oxygenation will increase rate of survival without severe disability by 6 months post-randomization and to be cost effective. The results of patients on ECMO, 57 out of 90 met primary endpoint, survival rate at 6 months is 63%, mortality was 37%. For conventional ventilatory support, 41 of 89 met primary endpoint, survival rate at 6 months is 47% and mortality 53%. Recently, in patients suffering from COVID in severe respiratory failure, the limited studies on patients with COVID-19 requiring ECMO have thus far demonstrated poor survival. Overall, this study demonstrates promising outcome with most patients alive and no longer receiving ventilatory care and ECMO support, and 73% discharged and no longer receiving oxygen. Complications has been minimal. There were no ischemic stroke, inotropic support, and tracheostomy requirements because of the early extubation strategy. Mortality was 15%. While this study has limitations because it is still an early retrospective report on 40 patients, single access dual stage veno-venous ECMO with early extubation appears to be safe and effective in patients with COVID-19 respiratory failure. Another study from 2009 on influenza patients A, influenza A, H1N1, 68 patients with severe influenza associated ARDS were treated with ECMO. Survival rate was 71%. Extracorporeal CPR is a method of cardiopulmonary resuscitation that uses ECMO as an adjunct to standard CPR. The application of ECMO allows the return of cerebral perfusion in a more suitable manner than with external compression alone. CRRT during ECMO not only does multiple organ dysfunction syndrome during respiratory and the cardiac failure predispose patients to acute kidney injury, but also factors associated with the ECMO system itself: non-pulsatile blood flow, hemolysis, activation of the coagulation cascade, and systemic inflammatory response caused by blood exposed to contact with the artificial surfaces of extracorporeal circuit. Other common reasons for renal replacement therapy in ECMO-treated patients include acid-base and electrolyte disorders and fluid overload, which is related towards survival. It is estimated that approximately 25 to 68% of patients treated with ECMO need renal replacement therapy. According to a survey based on 65 international ECMO centers, renal replacement therapy in ECMO patients was introduced as a treatment for fluid overload in 43%, prevention of fluid overload in 16%, acute kidney injury in 35%, and electrolyte disturbances in 4%. The early introduction of renal replacement therapy during ECMO may prevent fluid overload and enable treatment even with high volume of pharmacotherapy. The most commonly used renal replacement modality in ECMO patients is continuous renal replacement therapy, which includes SCAF, CVVH, CVVHD, and CVVHDF. The regional citrate anticoagulation is a growing importance for CRRT, but it cannot be used for ECMO. If CRRT is combined with ECMO, no additional anticoagulant is required. There are three main modalities of combining chronic continuous renal replacement therapy and ECMO with a separate vascular access and CRRT machine, and this option requires additional vascular access and is most often commonly used when CRRT has been used prior to introducing ECMO. The advantage of this approach include no interference with either the systemic or ECMO hemodynamics, and the ultrafiltration is controlled by CRRT machine. Another procedure is connecting the hemodiafilter in the ECMO circuit using the blood flow forced by ECMO, the so-called inline technique, or combining two independent extracorporeal circuits, ECMO circuit and CRRT machine, with the use of an external machine. This figure illustrates the use of a hemofilter in ECMO circuit after a roller pump, the inflow to hemofilter, and then the outflow back before roller pump. And this figure demonstrates the presence of CRRT machine in line with ECMO machine. By centrifugal, after centrifugal pump, the inflow to CRRT machine and then the outflow from the CRRT machine is returned back in the same line. However, combining these two methods may be a cause of several technical problems, most often associated with CRRT machine pressure alarm in CRRT inlet and outlet lines. This is another configuration where the line or the inflow for CRRT machine after oxygenator and the outflow before centrifugal pump. The future for ECMO: increased accessibility and use, reduction in cost, insurance and governmental support, smaller line volume oxygenator, coated tubes, and smaller or portable ECMO machines. And at last, I would like to thank organizing committee and my colleagues, and thank you.
Well, thank you very much, Professor Montasser, for this elegant presentation.
and I am proud and I have the honor to present my friend, Professor Madhukar Misra. He is a professor of clinical medicine and nephrology at University of Missouri. He is the current director of the medicine specialty clinic at the University of Missouri. He is also the current director of inpatient renal replacement therapy in University of Missouri, and the current director of the fellowship training in nephrology at University of Missouri. Professor Misra was the former president of the International Society of Hemodialysis from 2010 and 2015. He will present today about the nephrologist and the hemodialysis machine, why we don't see what we don't know. Professor Misra.
Hello everyone and salam alaikum. First of all, let me express my thanks and appreciation to Professor Sharkavi and his team for inviting me to speak during this conference. It is a pleasure to be with you, even though I'm at a remote location. I have been given 20 minutes, and so I'll go ahead and get started right away. I'm going to discuss two potential complications that can happen during hemodialysis procedure. It is important that we understand them as nephrologists because they can cause great harm to the patient. First thing to remember is that we cannot view hemodialysis machine in isolation because it is part of an assembly. So besides the machine, we have the extracorporeal circuit, the dialyzer, the water treatment system, and so on. And problems with any of these components can lead to overall adverse events and adverse patient consequences. So we need to remember that. When you look at what goes wrong during hemodialysis in terms of various adverse events shown on your left and the frequency of these events shown on your right. This data from Pennsylvania Patient Authority gathered over time shows very interesting observations. So, for example, the commonest error that happens during hemodialysis is giving the wrong medication. That is not unexpected because on an average, patients take 15 to 20 pills a day. Interestingly, the second most common reason for adverse events during dialysis was failure to follow protocol laid out in very clear defined terms. This failure to follow protocol may be on the part of the nurses or the technicians or the doctors, but the fact remains that we often fail to follow protocol leading to adverse events. And most interestingly, equipment failure or blaming the machine for adverse events ranks very low on the list. So what are we essentially trying to achieve during hemodialysis? What we're trying to achieve is shown to your left. And I do not need to go through details of each one of those because it's very obvious. At the same time, what we're trying to do is to prevent some hazards from happening. Those are shown to your right, including not losing blood, not hemolyzing blood, not introducing air, avoiding infections and toxicity, and anaphylaxis. Now, this is a cartoon that I will essentially use to go through the complications and the questions that we'll discuss. First of all, we have this AV fistula that is being used to draw blood from using a roller pump that pushes the blood in a forward direction through the dialyzer, and the blood is returned by venous line. We also have the dialysate system where purified water comes in, mixes with acid and bicarbonate concentrates, and circulates on the dialysate side. Inbuilt into the system are various alarms, as is shown here, both on the blood side and the dialysate side, to monitor various pressures, and these act as safeguards to prevent potential harms. Now, talking of prevention of harms, it is important to remember that these monitors or alarms can only detect a potential harm. They cannot prevent a potential harm. But sadly, more commonly than not, when you see alarms going off during hemodialysis, the most common reaction of any person who is near a machine and hears an alarm going off is press the reset button or the mute button without bothering to figure out what's causing the alarm to happen. Because alarms are not fail-safe. We should not only avoid altering alarm sensitivity and range, we should also discourage disarming alarms, remembering that blood alarms only isolate the patient by shutting off the blood pump, clamping the venous return, and stopping the ultrafiltration. So let's now talk about the blood side of this whole circuit. As I showed you before, the blood is pumped into the circuit at the rate of 200 to 600 ml per minute using two roller pumps that compress the tubing in between them, forcing the blood forwards along the tube. And this tubing can be adapted if required. It can be the pump can be operated manually, and the blood flow rate simply reflects the rotations per minute of the pump and the tubing volume in between the two roller pumps. The actual pump is shown here. Now, one important thing to remember when we're talking about the blood pump and the tubing before and after it, that there are two parts to this whole system. One is the pre-pump segment that has the negative pressure, and the other is the post-pump segment that has the positive pressure. What does that mean in terms of practical implications? First of all, the pre-pump segment with negative pressure is prone to complications like air entry. Because of the negative pressure, air can easily enter the system because of the faults shown here related to the arterial needle, the pre-pump tubing, the open venous catheter, and so on. Likewise, the positive pressure segment has its own issues. Most scary of them is loss of blood because of the positive pressure in the post-pump segment. Now, we talked about the various monitors that are distributed across the system for safety reasons. These monitors are important because this monitor for monitoring the venous pressure uses a pressure transducer in the venous chamber, as is shown here. And the pressure reflected in the pressure transducer allows for determining the positive pressure on the axis. It also allows, this venous chamber also allows the separation of the blood from the air. And then comes the question of how do we monitor these venous pressures? So there can be low venous pressure alarm from the venous air trap because of either low blood flow upstream or disconnection downstream. There can be high venous pressure alarm, and these are more commonly recognized due to either high blood flow through a narrow needle or a clot in the venous strip chamber, and various other reasons shown in the panel to your right, including spasms of the venous limb, kinks in the return line, or needle malposition. So with that background, here is my first question. 2 hours into hemodialysis, a patient complains of feeling weak. He has been complaining of cramps for the last 2 weeks. Blood pressure is now softer at 110, started with 150, heart rate is 75, regular blood flow in the dialysate flow shown here. Nurse comes in, checks the machine, no problem, turns the ultrafiltration off, reduces blood flow to 200, starts dialysis again. But the patient is not feeling better. He's now feeling cold. Blood pressure's dropped to 80. Now the nurse starts doing what is normally done in hemodialysis unit, including starting saline, raising foot end, giving blankets. Machine still does not alarm. The dialysis is continued and the patient crashes. Nurse now comes running back, notices a blood pool below the dialysis chair. Blankets are removed, and the nurse sees a horrific sight. Blood is being pumped onto the floor at a massive rate. This is a complication that we can hope never we see again. What happened? Why did the pressure alarm did not sound? What happened was that the venous needle got dislodged. But the question is, why did the pressure alarm not go off? Well, if you think about it, the venous pressure reading during hemodialysis by means of the pressure transducer is determined by what of these four components? Is it the pressure in the axis? Is it the needle? Is it the blood flow rate? Or all of the above? And the answer is all of the above. So here's a cartoon for you, which shows essentially an AV fistula arm with the blood going in to the dialyzer and being returned to the venous axis limb shown in blue. And attached to that return line is a venous pressure transducer which is at a height from the AV fistula. Keeping this diagram in mind, now let's imagine a state of no blood flow. In that situation, the venous pressure reading will simply mean the pressure within the axis. However, when the blood is flowing, all the components that determine the venous pressure will come into action. So when needle slips out from an axis but remains at the same height, the pressure reading will only drop by the amount of the axis pressure. Again, the axis pressure is no longer being measured, but the needle, especially if it's a narrow gauge needle at a high blood flow, will still contribute a large component of the total venous pressure being monitored, and may contribute so much to the overall pressure that despite losing the intra-axis pressure, the alarm may not go off. When you look at the relative pressure distribution between the grafts and the fistulae, you find that in general, the graft pressures are much higher than the AV fistula pressures. Almost 90% having more than 40 millimeters of mercury pressures in the grafts as compared to only a third of the fistulas. Remember, the lower detection limit of the venous sensor is placed generally about 30 millimeters below the venous operating pressure, and so it may be difficult to detect venous needle dislodgement from AV fistulas. Here is what I'm talking about. The arrow shows you the venous operating pressure. The lower limit of that window is about 40 millimeters or so below the operating pressure. Okay, so in an AV fistula with a low pressure, for the alarm to sound, if the needle dislodges from the axis, the pressure drop should exceed the pressure difference between the operating pressure and the lower alarm limit. Since the fistulas have lower pressures to begin with, this limit may not be crossed and the alarm may not go off. That is the reason why in our patient the alarm didn't go off. Remember, there was complaints of cramps for the last 2 weeks, and besides cramps, these are typical patients who are more prone to have venous needle dislodgement. And one must be very aware that access is kept uncovered and various other precautions are followed to prevent this complication from happening. So what should we do? Well, first of all, we should never set wide alarm windows for venous pressure monitors. We should always monitor patients, especially when alarms are reset. We should secure tubings, connections, and cannula, and definitely avoid covering access sites. because we can lose a large amount of volume and cause death of a person, especially in our patients whose reflexes are hampered to begin with. They essentially behave as if they are beta blocked. And this complication is not hypothetical. It happens both in-center dialysis and home hemodialysis. And a lot of nephrologists and nurses are unaware of the limitations of venous alarm. Let's now move on to the complications related to the dialysate side. This is a simplified fluid pathway where you can see on the top water entering, being warmed, being de-aerated, and then of course going through the proportionate pump, mixing dialysate concentrate with the water, and there are several safeguards for conductivity and monitoring temperature. There are bypass valves which basically protect the dialyzer from being exposed to the dialysate in case there are problems. And this is how the dialysate circulates countercurrent to the blood flow within a dialyzer. Several pressures are being monitored too. Remember the three-stream method of preparing a bicarbonate-based dialysate, which consists of the water being mixed with an acid component and a base component. The base component, of course, has bicarbonate in it, and the acid component has two things: electrolytes and an acid. An acid, which is an organic acid in form of glacial acetic acid or sodium diacetate or citric acid. Regardless of the organic acid, one must remember that all organic acids are potential bases. They are potential bases, and so they contribute to total buffer base. So if the base concentrate of the bicarbonate in the bicarbonate bath was 37 to begin with, and the acetic acid coming from the acid bath was 4 millimoles, after the reaction, the loss of 4 milliequivalents per liter of bicarbonate is gained by 4 milliequivalents per liter of sodium acetate. So the total bicarbonate, or the total buffer base available in the final dialysate, is unchanged if you're using acetic acid in the acid concentrate. Some of you might remember the device issues or the concentrate issues reported several years ago with the GraniFlow bicarbonate concentrate powder. What had happened was that sodium diacetate was the acid component in the GraniFlow. I'm sorry, the dry powder of sodium acetate was in the acid concentrate GraniFlow, not the bicarbonate concentrate. But anyway, so the sodium diacetate coming from the acid concentrate mixed with the bicarbonate from the base concentrate and produced an overall bicarbonate concentration in the final dialysate of not 37 but 41 milliequivalents. And so here's your problem. We have a patient who's been on dialysis for 4 years, and you can see the dialysate prescription on the left. And 2 hours into dialysis, patient is not feeling well, complaining of palpitations, heart rate of 120, irregular, low blood pressure, and the EKG shows multiple ventricular ectopics. Patient is disconnected from dialysis. Usual measures are done. Blood is drawn, dialysate chemistry is drawn, potassium is administered to the patient, and cardiology is called. This is similar to what happened several years ago, based on the example that I showed you using GraniFlow acid concentrates, in that almost 50 dialysis patients were hospitalized, and what was found was that their mean serum bicarbonate on presentation was high, and in fact more than half of them had more than 30 milliequivalents per liter of starting bicarbonate. And what had been noted was that the overall bicarbonate concentration was high, because of the fact that sodium diacetate was being used. So, important to remember that if we do not pay attention to what total buffer base is going into the patient, we may end up having complications related to too much alkalemia in the patient, which may then lead to various types of cardiac arrhythmias without us even realizing what can be the potential issue. So what I've tried to show you in the last several minutes is that hemodialysis machine cannot be viewed in isolation because it's part of a system. We often have this tendency to reset or mute the alarms, whereas in fact, if we notice an alarming machine, we should try to problem solve and see what's causing the alarm to begin with, rather than resetting them all the time. And that is why a basic understanding of the functions of the machine, the blood side, the dialysate side is required. We are not expecting nephrologists to be technicians, but we do want them to be aware of what's happening to their patients, because it is vital we all recognize that patient safety is paramount when we dialyze our patients. Thank you very much for your attention.
Thank you very much, Professor Mizra, to be with us. On behalf of myself, as well on behalf of the organizing committee, as a president of this Congress, a warm welcome to be with us in Cairo. Hopefully that we can meet physically next year. I can now open the discussion for this element of discussions should be carried out by Professor Magdi Shar'awi, who will carry the arrangement of questions to our eminent professors. Please.
Thank you very much, dear professors. First question, Professor Tariq Elbaz. There is a question about the Arabic gum. Does it have any effect on the microbiota or in general health? Professor Tariq.
But according to the literature that has been published over the years, not coming from this part of the world, as a matter of fact, Arabic gum has not showed any significant results. I know that many people... Yes. Various complications are associated with this. Just because it works and helps some people, scientifically speaking, it doesn't mean that we should use it as a prebiotic. I know it works. It does work like many other things, but when it comes to science, this is the answer I have to offer.
I have another question to the
Go ahead,
Professor Tariq Elbaz again, please. Assalamu alaikum.
Alaikum salam.
أهلا بحضرتك. I have a question related to microbiome or the naturally or the medications that you can give in chronic kidney disease as microbiome. How long shall we give it, Dr. Tariq?
Well, there hasn't been any publications looking into this particular point. How long? I think it should be a long-term thing.
Lifelong, yeah.
Lifelong, just like eating any diet. You advocate this healthy diet as long as you are living.
Yeah.
So it's just the same. Improving the gut microbiome is very beneficial, not just only for CKD or other diseases, but generally for the well-being of the human being.
Thank you, Professor Tariq.
Professor Tariq, there is a question from the audience about the endoxyl sulfate and bicresol, because they are also increased in patients with liver disease. So they ask, is there a role of liver in removing these toxins in patients with CKD?
That's a very, very nice question. The capacity of the liver to remove endotoxins is surpassed by the excessive amounts that are produced by the dysbiotic gut microbiota. Physiologically, it should be removed by the liver, but now you are addressing a liver that is diseased already, that is not detoxifying what it should be doing. So liver disease, chronic liver disease with the presence of these toxins is going to be another added problem to the blood vessels, causing more and more excessive permeability and vasculopathies.
Can I add a point for this question? For the,
Yeah, sure.
Yes, for these protein compounds, it's a 95% protein binded, and subsequently with chronic liver disease, this compound will be very limited according to the serum albumin level as well the serum prealbumin. On the other hand, its excretion is mainly by peritubular organic anion transporters. So I think if you have a chronic liver disease and these toxins, you have two optional ways of removal. One is the free level will be increased as the serum albumin is dropping. Second is the renal tubular handling should not be affected, to my opinion.
Right.
Dr. Yasser.
Professor,
Question
Thank-
for Professor Nicole.
thank you, Professor Tariq, for your.
Thank you, sir.
Thank you. Professor Warren, please.
Go ahead.
Yeah.
Thank you.
خرجت?
Okay.
So, okay, we now to Professor Muntasir.
Okay, Professor Muntasir.
دخلوها تاني. It's
برضو.
not there? Okay, okay, we'll start with Professor Mezra. Professor Hasham has a question.
Thank you again, Professor Meza. From my side, as a research and development director for many years on the development of hemodialysis membrane asphalt for the extracorporeal circuit, I wish that to add from your side the value of some of the clinical benefits of airless blood tubings, as we know that the sensitivity of microbubbles in different hemodialysis machines are different. And one of the main causes of pulmonary hypertension in CKD on dialysis population is the pulmonary hypertension. So if you have an adding information of the value of the airless blood tubing sets.
So thank you for the question. I think we all know that air embolism is a real threat to our patients. The problem is that even when we do all the precautions that we do, small micro air bubbles still filter through and get lodged not only in the lungs but also in the brain. And so it all depends on two factors. One of them is the size of the bubble. So for example, if the size of the bubble is in the range of 50 micrometers to almost 200 micrometers,
Exactly.
they can get lodged into the pulmonary circulation. In fact, there was a few years ago a publication in American Journal of Kidney Diseases which actually highlighted the presence of these bubbles even in the brain. So microbubbles are a problem. Now, whether or not finer membranes, the newer membranes of the dialyzer and the tubing can prevent that is, I am not aware of any literature in support of that, that it can prevent lodgement of these bubbles in the lungs.
I think it's one of the future research on that issue of the high efficient and airless. We lack the all the researches on blood tubing. We are concerning on the dialyzer, while the blood tubing, I think it's a very important topic for the research. I would like also to ask a question accordingly to the pressure control
مخرجه forever.
inside the dialysis machine.
دخل تاني.
Sorry, what is the question?
The pressure control in hemodiafiltration inside the dialysis machines.
Right. So the pressure control basically consists of, broadly speaking, 3 areas of control. One is the blood side, one is the dialysate side, And when you talk about the blood side, the two major components of pressure control relate to the arterial side and the venous side. So as I said, the way the pressure is measured is through these monitoring chambers that I showed, for example, the venous chamber, and so is the arterial chamber. There is a pressure transducer that is attached to these so-called chambers, and the pressure measured is transferred into an electrical signal, and we read the pressures. So I think the most important thing for us as nephrologists to remember is that the two major complications that are highlighted, which relate to negative pressure on the arterial side and the positive pressure on the venous side, can be minimized by keeping in mind certain very, very common sense procedures. And one of them is, of course, keeping the needle sites open so that you're always visualizing that the axis is unexposed, but also making sure all the connections, for example, are tight enough. We talked about air bubbles. And one of the important things to remember about minimizing air bubbles, because when air bubbles enter, obviously the alarms go off. But in order for the alarms to go off, there are certain things that we have to keep in mind. So for example, the venous air chamber has that blood-air interface. And so we need to keep the blood-air interface minimum to begin with. If we keep too large of a window of air-blood interface, then we will have to have a large amount of air enter into the venous tract before the alarm goes off. Likewise, avoiding using extra high blood flow rates is another thing. So if you're using narrow gauge needles with excessively high negative pressures because of the high blood pump flow rates, then we are more likely to introduce complications like air embolism. So again, avoiding high negative pressures on the arterial side, avoiding pressures not too high, not too low on the venous side are the two ingredients. How do we do that? Obviously depends on a lot of things. The two key determinants are the blood flow rate and the needle. On the venous side, the axis does not contribute much in terms of pressure to the venous pressure reading. Because as I showed you, the AV fistula, because of the tributaries that over time, you have lower pressure as compared to the graft. And so if you are operating in a low pressure environment and the window is just 30 to 40 millimeters below the operating pressure, the pressure will not drop. And as long as the needle is sitting on the arm, you may lose a lot of blood without the alarm going.
Professor Mizra, it's an excellent presentation. I have an inquiry. As we are in Egypt now, we try to write the guideline and we try to involve HDF. We want to know what is the situation in the United States regarding HDF. Will it be incorporated into the system or not?
Excellent question, and inshallah it will be. The answer is right now the FDA does not approve use of HDF in clinical situations. I am in the US, but I must say that unfortunately FDA is too strict with approving treatments which have been well to be of benefit, including, for example, I'm reminded of icodextrin. When I was in England, I had been using it, and it took me almost 5-7 years before it was introduced into the US. So the answer is no, HDF is not authorized to be used in US right now.
Next question.
My dear Professor Mizra, how are you? Hello?
Sorry, say that again. I missed the question.
Yes. My question about high flux membrane versus high performance membrane. What do you prefer?
So all of our units use high flux membranes and high efficiency membranes. Now, as you might know, I am not very aware of what the trend is in America. Patients, anytime you increase the time by 15 minutes, they complain of having too much time on the machine. So we struggle to keep them on machine for even 4 hours. So the trend is use high blood flows, use high efficiency, high flux dialyzers, and get them out of the unit because the patients just don't like to spend an extra minute. As compared to, for example,
I can add an answer for Professor Dr. Tariq, because his question has two answers. The difference between high flux and high efficient is the molecule to be removed. High flux is high flux by sieving coefficient of beta 2 microglobulin above 0.6. And if you go to the Japanese classification, it depends on beta 2 microglobulin removal. While high efficient depends largely on definition on the KO value of urea. So there is no chance to use high efficient. It's a chance to use high flux, and all high flux filters are high efficient, but not high efficient is high flux membrane. So I come up by my last question. I think we fatigued you so much by our questions. We all understand the problem of FDA years ago from the alkali used and the patient's respiratory arrest and complications during hemodialysis. And attorneys in USA got a lot of money, billions, on that. My question is, not all hemodialysis machines are equipped with the pH meters. So do you recommend with me that it should be on the basis of pH meters in all hemodialysis machines?
Yes, so if the machine is not equipped with pH meters, the routine recommendation is that at the beginning of the day of the shift, then we should use actually portable pH meters to check the pH, not only the pH, but also the conductivity. And the best way to do it is, of course, to use the dialysator to send it to the lab. But that is a time-consuming process. Portable pH meters and portable conductivity meters are the way to go in case we don't have machines with pH meters attached.
Thank you very much.
Last question from Professor Kamal.
Thank you, Professor Mezra, for this excellent talk. And just a very brief inquiry, basically, about the high cutoff dialysis. Do we have some options in the machine just to run this type of dialysis?
So the high cutoff dialyzers basically are being used, and a recent study that just came out of Boston highlighted the potential benefits. But again, the machine itself does not have any, at least from what I know for the current machines, have any features built in that will facilitate the removal of larger molecules, which high cutoff membranes do by using ordinary dialyzers. You have to have the actual dialyzer that has the efficiency to have large pore size so that you remove higher molecular weight solutes. But machine itself cannot do that. You have to, and I don't think any adaptation has been made so far. It is all dependent on the dialyzer membrane itself.
Yes, machine is blind for using high cutoff dialysis membrane, but remember that you cannot combine two therapeutic challenge, high cutoff and hemodiafiltration at the same session. So I think it's a blind technique using the machine of that.
Yeah.
So the machine has nothing to do with the high cutoff dialysis.
Yeah, exactly.
Okay. Thank you, Marika, for this very elegant discussion. And thank you, Professor Weern, Professor Elbaz, Professor Zaid, and thank you again, Professor Mezra, for a lovely session. And until we meet again physically, hopefully next year. Thank you. This concludes this session.